Good evening, everyone. My name is Dr. Wakely, and I'm a consultant neurologist. Today, we have another excellent line of talks in our BASH webinar series. This evening's topic is facial pain, an update on management. As you're all aware, cranial neuralgias, especially trigeminal neuralgia, are frequently encountered in neurology clinics and pain clinics, and they can present a real problem to both patients and to treating doctors. Today's talks will be focusing on what we should be looking for, what secondary causes we should be looking for, and how to manage these very difficult pain disorders. It's a pleasure to introduce today's speakers. We have Professor Joanna Zakrzewska, who many of you will have heard of. She's a world expert in trigeminal neuralgia. And this will be followed by Dr. Clare Daniel, who's a leading expert in the psychological aspects of chronic pain management and trigeminal neuralgia. So if you have any questions this evening, what I want you to do is just type them out into the chat bar. I will scan the chat bar at the end and I'll pick up any themes, and then I'll ask the speakers your questions for you. And also in the chat bar, I put a link, a web link to the BASH membership page. So for any of you who aren't members of BASH, this is something that I would highly recommend. And if you click on the link, it tells you exactly how to become a member. So without further ado, I'm now going to hand you over to Professor Joanna Zakrzewska, who is going to tell you more about cranial neuralgias. Thank you very much, Joanna.
Right, can you see the next slide?
Yeah.
Which is about classification. I'm going to talk briefly about classification, then obviously on trigeminal neuralgia, its diagnosis and management, about the autonomic cephalalgias, a tiny bit on glossopharyngeal and other neuralgias. I'll also allude to MS. So classification, this is a very old slide, but once you've excluded dental causes, then it's really looking at unilateral, continuous or unilateral episodic. And those in blue are all the ones that we classify as neuralgiform ones. I'm not going to be talking about post-traumatic trigeminal neuralgia, but that's one often inflicted by dentists in doing work. But I'm mainly going to concentrate on the trigeminal neuralgia. Now, there are two main classifications. You're all familiar with the IHS one, but the dental community or the oral facial pain community internationally have put together the ICOP classification, which classifies dental pain in much greater depth. So those of you who want to find out a little bit more about dental causes, TMD and things, that's the classification to look, published by Cephalalgia. And I think that's the problem now, that there are these varying classifications. If you look at the IASP one, it's very simple, just classical, idiopathic and secondary, whereas IHS puts it down to also include those with not just episodic pain, but also with concomitant persistent pain, and classify it a bit more carefully. Now, something that IASP, the International Association for the Study of Pain, and IHS try to do is to fit trigeminal neuralgia into a neuropathic condition, and so have this flow chart where you first say it's possible because the pain is distributed in the trigeminal territory, it's paroxysmal. And then if you identify that it's particularly triggered by light touch, it's probable, and it's the MRI that puts it into the definitive area, whether it's idiopathic, that is no cause found, classical, where there is a neurovascular, or secondary, where there is some demonstration of MS or tumors. So TN, if any of you want, this is these are all the papers that I've used to give you the clinical characteristics of TN. So everybody's agreed from those papers that it is unilateral in the trigeminal distribution, with only 3% being bilateral. And if they are bilateral, it's rare for both sides to go. Everybody's agreed on the description of it: electrical, stabbing, sharp, or burning. Timing varies. Most people will say it lasts seconds to less than 2 minutes. Can be a series of stabs, not a single stab. Number per day varies between 3 and 50, and you'll see why that's relevant later. But we're beginning to talk about this background residual pain that's there, but severity is high and remission is high in many of them. The triggers are very important. As you see here, 90% of them have got to have light touch triggers. Yes, some will have spontaneous ones. There can be some sensory changes. Examination, particularly when the dentist look with a good light, can show you an area of poor oral hygiene, and this really emphasizes it. And again, you may see in clinic an attack, or when you're examining the patient, touch a trigger point. And again, seeing an attack and timing it is of great value. So I use some diagrams to help me with this as well. And particularly we're looking at 1 and 2. That's the series and the breaks in between. Sawtooth is more in the tax, and I'll mention that later. But you can also get this one where it sort of goes down more slowly and stays, and that's what we call the concomitant pain. But it's important that this concomitant persistent pain is not of the high severity that an actual flare-up is. And again, if patients start to draw you these, then you're wrong in the diagnosis. An interesting paper is from a Turkish group who got patients to draw where their pain was, and they gave them colors to draw, and they also measured their anxiety and depression prior to gamma knife surgery. And what they found was that patients who drew their pain in a much wider area, as you can see in A, B, C, and D, were much less likely to have a good outcome, whereas those on the other side had much better outcomes. And I think, again, it reflects the diagnostic criteria being more careful and really looking at carefully where this pain is. And of course, it's linked also with depression, which Claire will cover in a moment. So we're looking at neurovascular compression being the most common cause, and these will show you here. It's got to indent, not just contact. Contact is very common, or even cause atrophy. And so here is the nerve coming from the face down here, and there's the compression. But you can get those with no compression at all. And then we're looking for MS and tumors, and hence the need, as we've said in the guidelines, all patients must have an MRI to resolve these issues. So management, again, which are the outcome domains you should be using, and how do those link to measures? Initially, the IASP did a lot about measures, but we're now realizing that outcome domains are important. And Carolina, my PhD student, found that, yes, of course, pain relief, duration, pain intensity are important, but other mandatory things are health-related, quality of life, ability to participate and satisfaction with treatment. And we still need to really map onto this some of the measures that would help us with this. So guidelines, I've worked in guidelines for TN since 2008 when we did international ones. We updated the European ones back in 2019. And then we did updated them again and really got involved with stakeholders from the Royal College of Surgeons of England. So the guidelines we've done in the UK are very much with all stakeholders, and BASH contributed to them, patients contributed to them. So we feel they're more involvement of all the stakeholders rather than just the European guidelines. So you'll find everything in there. So that's your crucial site. So here are the sort of summary of those papers. So the first line medications remain carbamazepine and oxcarbazepine. I must say I prefer oxcarbazepine because it has fewer side effects and slightly less drug interactions. But you have to watch the hyponatremia, which can be quite low, and it is dose related. So those remain the two favorite drugs. Lower evidence we've got is in the secondary care sector, really, is lamotrigine, baclofen, gabapentin and pregabalin. I must say I've really, and especially now that they've become controlled drugs, gabapentin and pregabalin are not particularly effective. Lamotrigine is a good drug. And then you can use polytherapy. So if you've got one of the drugs at maximum dose, you could then add in another drug, but there is no evidence for that. And then acute management is crucial importance, but there is very low evidence for this. So again, lidocaine ointment and sprays and injections are useful. This is where the dental community comes in, because many of these patients will have pain in the lower part of the face and have an identified trigger, so that the dentist can give an injection with lidocaine followed by a marcaine. So it gives them a few hours of pain relief and allows the oral drugs to work. Sumatriptan has been suggested, as you are mostly familiar with its use in other conditions. We haven't had great success with it. Botox, there is a trial running at the moment in Denmark. There are some papers about its use, but it's not an immediate effect. So it's watch this space, and how often can you give Botox is important. And then if you're really stuck, it's into infusions, admissions. In fact, I've just been organising one today, phenytoin, but better fosphenytoin, although it's much more expensive. Lidocaine, I'm not convinced about its value in this condition. And there's also a single paper about the use of lacosamide as IV. And it gives you a chance to put in the oral medications. But there's a lot about the non-pharmacological management, which Claire will cover, that I think is so important in these patients that need to be admitted. So the dentists can give the lidocaine and marcaine. They've got much finer needles than anybody else. Lidocaine spray is useful. That again needs to be prescribed either by the GP or a dentist, and they just spray it in the area of the trigger. Very important that they lean their head to the side, let it bathe it for a minute, and then spit it out. And that again can be helpful. And identifying that is important to try and differentiate from other dental pains. But we know the side effects are common. This was using the adverse events questionnaire from the epilepsy world, and the dark blue show you the tiredness, memory problems, the sleepiness, and the cognitive impact. And we picked that up again with cognitive psychologists, did some work with us comparing the TN patients with controls, and again showed cognitive impairment, sensomotor function. That's why they suffer from ataxia. I've had patients who've fractured limbs in falling, and these are very unpleasant, and the reason why patients will move towards surgery. So we've had new drugs. We've been trying new drugs. This is a highly successful drug. Took us a long time to do it, but unfortunately the phase 3 study has been put on hold at the present time. But there is another drug trial running. It's running in 2 places in the UK, at St Pancras Research Centre and at St Thomas's, coming to an end of recruitment by the end of September. And this may be another useful drug for neuropathic pain as well, and particularly patients with a background of concomitant pain. And it's the same design as for the Vixatrigen, that patients get an ability to try the drug first, and those who are responders to the drug are then randomized to either the drug or to placebo, because it's impossible to use carbamazepine or oxcarbazepine in conjunction with this drug. So it is showing improvement on the run-in data. We're now showing that it is having an impact, so it's worth exploring this. It's the first 2 drugs that we've had that are not being registered for use in epilepsy. So surgical treatments, very difficult. At which point do you refer patients? I like to refer them early so that before they are troubled by their side effects, they can make some rational decisions. So again, we have no RCTs of microvascular decompression, so it's on grade, but there's no doubt that that gives the best outcome. And it's here is the nerve and the vessel there, and the neurosurgeons move it out of the way. And because they're very delicate with it, you're not going to get any sensory changes. The other procedures are all ablative treatments, and so they will result in sensory change. And of course, the time frame is not as good. So in MVD, from the best of the literature that we've got, which is a large series, we can say 85% can be pain-free at 2 years, 70% at 5 years, now extended probably up to 10 years. Mortality has dropped considerably since we first started. The main problems are the CSF leaks. And so that's why it's so important that you have a neurosurgeon who does these procedures frequently. It's neurosurgeons who are skilled in posterior fossa surgery, and that's what we're very keen to establish. Where are the neurosurgeons who are good at these procedures and have low complication rates? So overall, major surgery is those which I've just analysed there. Minor surgery, we're talking about 50% of patients will be pain-free at 4 years and hopefully off drugs as well. But they will have sensory change, and that will be just local, just like a feeling of a slight dental injection, but it can be severely numb, and it varies in the number of distributions. It can be all 3 distributions, it can be just one area. We have found of great importance is a clinical nurse specialist who follows up our patients, and we've done an audit of this using our medical students and shown that 50% of patients phone for more pain management, but a lot ask about drug use, and sometimes they're much more open when they're talking to a nurse about how to use their drugs, although all get issued with leaflets about the use of their drugs. We have run successfully a multidisciplinary clinic, which is one neurosurgeon skilled in posterior fossa surgery and myself as the physician. And over an 11-year period, what we've shown is that 54% of patients end up having surgery, 55% are pain-free and off drugs, because these include not just the microvascular decompressions, but the other procedures. But those who stay on drugs, we even in that group have 16% of patients who may at some stage be able to be pain-free, which suggests that it isn't as progressive as a disease as we thought. So this is the care pathway that we have initiated at UCLH and audited throughout. It's also been audited by an outside company, Biogen, with outside psychologists, and satisfaction is high with this. And this is what I'm trying to replicate nationally, that these centres that can follow this pathway are available nationally, because you'll hear more about the importance of supporting these patients in a non-pharmacological way. MS, we did a review of those, systematic review. The importance is to note that TN can be the presenting feature, and they're more likely to be bilateral, hence the need for an MRI scan. We've written 2 papers about comparing them to the standard classical TNs, and also looked at their journeys. And overall, what we find is, yes, we can get them reasonably controlled, but we're quite pleased that we get them in a better place than they were before they came to see us. But the MS patients are very difficult to manage. I'm quickly just going to run through the tax, which I think probably most of you are familiar with. Sunct and Sunna are probably one and the same thing. And there's a lot of papers about these. These are some old ones. I like the thought of a tick versus a tack. And just as a summary here, just to show you the big difference. I think cluster headache doesn't really come as a problem, but it's the SUNCT and SUNAs. And is this a continuum from one to the other, or are they two separate entities? But as I said, there are more frequent attacks with SUNA. The attacks tend to be longer. It tends to be more in the first division rather than the second and third. And they have to have really quite a lot of autonomic features: red eye, runny nose, redness. They can have some migraine features. Cold wind is a big one for them. Lamotrigine works better for this group than does carbamazepine. Paroxysmal hemicrania continua, often not such a problem, but again, a useful one to try out if you're not quite sure, because indomethacin is a diagnostic drug. So giving them a trial of 3 weeks of indomethacin can help to sort this one out, because they do respond remarkably fast to indomethacin. So Giorgio Lambrou has published an algorithm of management, and you see it's lamotrigine, oxcarbazepine, but these patients also benefit from a microvascular decompression if they have nerve compression. Glossopharyngeal, the only difference is the location here and the fact that it's provoked by swallowing and coughing, and they can sometimes get vagal effects and therefore faint during the procedure. Again, we do MRI scans. We look at an OPG, which the dentists do, for an elongated styloid process for Eagle's syndrome. I'm not totally convinced about this condition, pretty rare. Management exactly the same as for trigeminal neuralgia, so no difference there. In the other neuralgias, I'm sure you know about postherpetic neuralgia. The other ones are much harder to manage, occipital ones, and do well with nerve blocks, which I'm sure many of you are familiar with. Patient information is important. Brain and Spine Foundation have a booklet which we need to update there. And there are support groups, both a UK one and international ones, which are important. I like our patients to get the Ottawa Personal Decision Guide, which they get when they come to the MDT clinic, because it helps to focus them on which is the best care pathway, and it can change as their pain develops. And a plug for my book, which has been written by over 36 experts, including Clare Daniel and patients in here, CPD, as well as lay summaries for patients. So thank you very much, and I'll hand over and stop sharing.
Right, thank you. Wouldn't have done that without you, Joanna, thank you. So following on from Joanna, I'm going to talk about psychological approaches to the management of trigeminal neuralgia. What I am going to say applies to a lot of different facial pains, so I don't want you to think this is just about TN, although some bits will be specific to it. So in terms of the aims, what I'd like you to go away with is the idea that any psychological process, any distress with somebody with pain is quite normal. I want you to be able to walk away and understand the experiences of people with TN. I have some understanding about how clinical psychologists work in pain management, but I'm not going to go on at great length about that because we're quite few and far between in terms of psychology in pain, let alone TN. So I'm also going to really focus on the things that you guys can do, even though you're not psychologists, to help patient care. And Joanna sort of touched on a bit of that as she's been talking, because it's not just about giving medication to these people, it's about helping them to understand. But I'll go on about this as well. So apologies if you know this already, but I just think it's really important to emphasize that everybody who experiences pain, no matter who we are, patients, you, me, anybody, there's always psychological factors involved in pain processing. So I've had a lot of colleagues, medical colleagues in the past, Joanna's not one of them, who have said things like, oh, this pain has a psychological overlay, or there's a psychological something within this pain. Well, you can say that for every pain, so it's actually pointless saying it. The reason why I'm saying what I'm saying is that we now know that a lot of people think there are pain pathways that go straight to the brain and that's how we feel pain. That's not the case at all. Even before we have the experience of pain, what our brains do, we're scanning, of course, all the time, and our brains are scanning and we're taking in the cognitive input and our present cognitive processes that are going on, the emotional input, and also our current mood, and any sensory input that's happening. And it's not pain that comes to the brain. Our brain just detects that something has changed. So then all that information goes into the brain makes sense of it. And if your brain is thinking, this is quite dangerous, I need to do something about this, or it's a threat, then you get the output of pain. Because it's an alert system at this point. It's an alert system. It's telling us to move away from something that may be dangerous. We have a stress response, an emotional response, and of course, the behavioral or action response. So what I've just said there is an absolute normal processing of pain. It's for everybody. So my point being is psychology or psychological processes are always involved in pain processing for everybody. Why am I really harboring on in this point is because unless you take that integrated understanding of pain, you'll end up thinking about pain in a very dualistic way. And this is where some of the problems happen with people with long-term pain, including TN. So if you're thinking in a dualistic way, you'll have a patient comes to you and you'll be thinking, okay, there's pain here, there's something wrong with the body or the face or the head. There must be a medical explanation for this. I'm going to scan you. Now, as you may well know, a lot of people with different types of chronic pain, including TN, you might put them under a scan, but it shows as normal. And if you hold on to this dualistic model, you'll then shrug your shoulders and go, well, I can't see anything. You know, the scans are okay. It must be something psychological. The pain must be made up. It's not real. And then that's where labeling of the patient start. The patient's a bit mad or the patient's a bit odd. And then that's when we start hearing words like the patient's somatizing or it's functional pain. Now, I'm not sitting here saying somatizing and functional pain doesn't exist, but those phrases are overused in the chronic pain field. And it's purely because people are taking a very dualistic, unhelpful view. So in the absence of medical explanation, i.e. investigations come back as normal, and if the patient is distressed, which as you will hear in a minute, they are always very, well, not always, probably I would say 90%, 95% are very distressed. And there tends to be a quick leap into, well, the pain's not real. When actually believing a person's pain is real, and actually it's just purely medical technology that isn't yet sophisticated enough to show the causes of all pain. Just saying that to a patient is the first step for them to think, oh, okay, this person's listening, this person's understanding. So that's really important. It might seem quite basic, but it's absolutely essential. Why is this a problem if you stick with your dualistic understanding of pain? It tends to be the case that then patients get labeled, particularly with psychiatric labels. And if you can imagine, you've had pain for, let's say, about 10 years, or even a year, and you're not getting a good explanation for it, and you're being told that it's something psychological, or you might need to go and see a psychiatrist, patients become very, very angry, and your relationship with the patient will rupture. They'll feel very unheard, they're very misunderstood, and you're at risk of misdiagnosing them as well. So, experiences with and the impact of TN. So it's not just as simple, obviously, as somebody just experiencing pain and that's it. When you've had pain for a while, there becomes a real impact in terms of psychological impact, social impact, behavioral impact. And I'm just going to show you a slide now. Hopefully my animation will work. So this is something that it's a slide that I made up for the book that Joanna's just mentioned. It's in there. So, but it's a very typical scenario of somebody who might come with TN. So you just have to follow my blobs as I put them on. So someone might come in or develop a sharp pain in the cheek. And of course, what they do is go to the doctor. But the doctor often doesn't know what it is. A GP often doesn't know what it is, but might prescribe something. But often that doesn't help. So the pain gets worse, and so they might go to the dentist and again, and on the third visit, a tooth's taken out. But that's not helpful or not helped, and therefore the person gets more scared, and the green blobs are about the sort of psychological element to this experience. Then they might go back to the GP, but because of the course of the system that we have at the moment in England, it's someone else that they see, and they also don't know, and they also suggest the dentist. So they do go back to the dentist to get antibiotics. But of course, those don't help because it's not an infection. But the GP might also say, we'll go for a scan. Scans often come back as normal. Patients then think, this person, because they said that the scan's normal, this person thinks I'm making it up. This cannot be normal. I'm in agony. Then there's the social impact begins at this point. So this person, for example, finds it really difficult to communicate with their partner, that they find it really hard to kiss that person because they might touch their face and it will start an attack. And then particularly if they're young, they then start with the, this is not fair. I should be enjoying my life here. Then you get the behavioural changes. You can't sleep because you have pain. And there's also a fear of it coming on. So you imagine if you're frightened, you're less likely to sleep. Can't concentrate, if this person's a student, for example, can't concentrate on my lectures or at work. So they might begin to miss lectures or take time off sick. They're getting behind. They become anxious that their grades will suffer. They then get frightened about the future and then think, what's the point in studying, and may well leave university or college or whatever they're doing, or their job if they're doing a job. And then on the left bottom that you see, and then they'll start to panic when they go outside. So when I was working with Joanna, we found that a lot of people's cognitions and comments were about, what if I go out and I get an attack? It's sort of unbearable for them to think about that. So they get frightened when they go outside, or they don't go outside. They might start making excuses for social events. But unfortunately, also what they'll find is people around them, not everybody, but a lot of people don't understand chronic pain, particularly TN. So they might laugh and say, oh, it's just a bit of a toothache, or they just don't know what to say, don't know how to help. Now, then you begin with the unhelpful coping strategies. So the blue thing there, they might start to drink more alcohol to help them to sleep. But of course, that's going to impact on the way they feel. This person, for example, is working in a job in a bar. Can't do that because he can't smile and be cheerful, and he's also feeling quite anxious. He also can't go out for meals anymore because it's hard to eat. He feels very self-conscious when he's in a social environment, and he can't afford to anyway because he's given up his job. And the partner is now getting frustrated because they want to have a normal life, go abroad on holiday, and I found a lot of people just can't bear the thought of being on a pain with an attack of TN. So again, no one understands. So of course, this person now feels depressed. The pain's still getting worse. They're really scared. They then remember, or they might have remembered quite a while ago, that their mum died of tongue cancer. So they then become scared that it's cancerous. And if they can't find a cause, because of course at this point people are not finding a cause, and therefore you can't find a cure, then they start panicking about the rest of their life and it's not really worth it, and I don't deserve this. And that's where your mood can really go down. You'll notice that people do check their face or wherever the pain hurts quite a lot, and that distracts them, but it can also, obviously with TN, can trigger pain as well. And then it's a lot of, catastrophizing makes it sound as though they're making it up. They're not making it up at all. A lot of unhelpful negativity goes on, which is absolutely understandable. And we find that a lot of people just, when they have an attack, they just stop in their tracks and collapse. I remember working with someone and she just hid under a table when she got an attack. And there is this overwhelming sense of, no one can help me, why won't someone help? So it's really, as you can see, not just as simple as they've got a pain and that we just need to find a cure for the pain, because this scenario can start quite quickly. And it's very, very difficult situation for these people, as I'm sure you can imagine. Unfortunately, healthcare often doesn't help either. There's lots of misdiagnoses. I won't go into detail about those statistics. You can see them there. But we find that people are misdiagnosed and there are delays in diagnoses. And there are often unnecessary interventions, teeth being taken out, unnecessary dental surgery. As you can see here, more than 80% of patients that with one study, sorry, I haven't said which study it is, had at least one unnecessary dental procedure. And of course, people go to private healthcare as well to try and find out a diagnosis and a cure. And so they end up spending lots of money as well, which of course then has an impact on their social life. And what we find at a lot of, I'll just call, it says medical interventions, but I'll lump it into, medical healthcare, is that people who are very well-meaning, clinicians who are very well-meaning, really want to try and help these people. They want to try and send them for different investigations or different treatments, but that cycle that you see there is actually one of the most unhelpful cycles that people can get themselves into, or we can help people get themselves into, because these people get really hopeful. Let's pretend I'm a GP and this person's coming to me and they think I know when I'm going to find the cure or the reason for their pain. They get really hopeful, but then they get into a massive despair when treatments fail, and they go up and down, and their mood goes up and down into hope, despair, hope, despair. And actually this cycle doesn't reassure patients. It actually makes them feel worse and more anxious. It gives false hope and distress, which, arguably is not really ethical if we're giving false hope all the time. And it just reinforces this search for a cure. It doesn't necessarily resolve the symptoms, and it can be damaging. And I put ... because it can be damaging both physically, so they might have an unnecessary medical intervention, such as a tooth taken out, that can in itself cause damage and more pain. And certainly psychologically, it can be damaging as well. So the ability to say enough is enough to the patient, we can't go down this route anymore, is really difficult, because you're giving them the message that they think you're giving them the message that I can't help you anymore. So it's really difficult to give that message, but actually in the long term, it can be helpful. Psychosocial impact, just quickly going to give you some data there in a paper that Joanna's written. As you can see, I'd say those figures suggest, about 50% of patients, there's an impact on these patients, whether it be doing daily activities, depression, anxiety, and the catastrophizing, which I'll talk about in a bit. So there's a large psychosocial impact. So how we work in trigeminal neuralgia, or any facial pain, but I'm sticking with TN at the moment. There's a biological or medical slant to this, of course. They've got a biological medical problem. But of course, as I just outlined there on that busy slide, there's also a social and a psychological impact. And if the intervention just tackles one or two, maybe, it's not going to be that helpful for the patient. I'm not going to say it's not going to help at all, but actually you've got a better chance of helping the patient if you combine the medical, psychological and social ways of intervening or supporting these patients. And of course, we're talking about a multidisciplinary team here that involves medics, dentists, and also psychologists and physios. So this is the model that psychologists work with when we're working with people with pain, but it's a very simple model, and it's something that I will keep talking to you about, because it's actually that you can help people as well if you understand this model. That's the cognitive behavioral model that you can see in front of you there. It basically talks about the way in which we think as human beings. This is not just patients who are struggling, this is everybody. The way we think, or our beliefs that we hold, influence our emotions, our behavior, or what we do, and our somatic symptoms or sensations as well. And anxiety is a good example of that. If you're, let's say, spider phobic, and you see a spider and your thought is, oh my word, it's going to hit me. Spiders don't hit, it's going to bite me. Then you might become a bit panicked or anxious. You might tread on the spider or run away. And of course, you'll get the adrenaline rush and the feelings of anxiety. So that's an example of how those four things are all interlinked. So arguably, if I was to try and change one thing, i.e. maybe the way I think, it may well influence the other three. I'm not saying it's the solution, but it might help a little bit, or to some extent. The really important part of this model and your patient situation is that it's our interpretation of the situation that is the vital point when you're working with someone with TN. An interpretation is all about the meanings people hold, their understanding of their TN and their beliefs about TN, but also their beliefs about you and medical healthcare and everything. So it's your patient's interpretation that will kickstart that cognitive behavioral cycle in an unhelpful or hopefully a helpful way. Now, as I'm going to talk a bit later on, we can kickstart this cycle in an unhelpful way. We hear things that patients have been told that actually is so unhelpful, and it just increases anxiety and depression. So you can help people if you find out what their interpretation is. So when you're seeing a patient, or when one is seeing a patient, the target of, I've put this cognitive behavioral therapy, there's also acceptance and commitment therapy. Both at the moment are showing evidence to help people with chronic pain. CBT is a model that I use for people with TN, and we had some good outcomes. I'll come on to that as well. But ACT is also a type of CBT, so it's a bit confusing. But anyway, When you're medical and you try and address the pain, if you're purely focusing on the biological, of course, that's your target. The pain is your target. But when you're doing a multidisciplinary pain management intervention, you're targeting not only the pain, but also the impact. So that whole slide that I showed with that mess, you probably remember pain was just on the left-hand side, just in one blob. I woke up with a sharp pain in my cheek, I think it said. Pain management actually tackles the rest of that experience, and I think it is a mess. I call it a mess. It's not about getting rid of the pain. I don't tell patients we're going to get rid of the pain with psychology, because their pain's not psychological. It's not a cure. I don't even say to the patients, you'll have a pain reduction. They may well do, but I don't tell them that. What it does is support the patient to change the relationship to the pain and live life well alongside pain. That's the aim. We help people to understand their pain. You can really help people to understand their pain because they'll believe you, because you've got medical things behind you. If a psychologist talks about what their pain might be, they believe us less, but you're in a very good situation to help people to understand their pain so they're less frightened and they're more confident about their pain. We help people to increase their activity and reduce what they're avoiding for fear of increases in pain. We help to improve their mood, because we often find, of course, if you're depressed, you have low motivation and you're fearful of your pain. If they understand their pain, then they're less fearful. We help to help them to engage in activities even though they might have the pain. And if they do something, so that I said, for example, earlier on, that these people don't go out necessarily because it's what if I have an attack of pain? Well, what they would do in the program is to learn or develop skills what to do when they have an attack, not if, but when they have an attack, because they will do, not necessarily all the time, but there will be times when they go out and have an attack. So how are they going to manage it? Then we encourage them to go out and go out to this, whatever they're not going out to, whatever they're avoiding. And then hopefully what happens is they come back, they review that, and either the pain, the attack didn't happen, so they managed really well and their feared outcome didn't happen, or they managed the attack quite well, and their feared outcome of an attack didn't happen either. I mean, this takes quite a few weeks to do this, and I'm just talking in 5 minutes, so it's much more complicated than I'm sort of making out. We also help people to think about the communication between friends and family who often don't understand, and also healthcare providers who often can get into an unhelpful conversation with these patients. We help people to understand that healthcare, or particularly medical intervention, can help, but it's not necessarily the be-all and end-all. And Joanna gave an example of lots of side effects of medication. So we help them to understand where the role of medical interventions can be, but where it can become unhelpful. We also help them to think about sleep, because that's really important in terms of general well-being. And we help them to manage the inevitable episodes of pain. What people tend to do, of course, and it's absolutely understandable, is react very quickly in quite an unhelpful way. We help them shift that a little bit to responding more, not thoughtfully, because they haven't got time to think thoughtfully in that time, but just to respond in a way that they feel in a little bit more control. This interpretation, I said to you early on that this interpretation of the situation is really important. Now, this is what we really focus on a lot in the program, and this is where you can also focus. I would say to you in your clinics or wherever you see your patients, I would always say to a patient, what do you think is causing your pain? Now, often they'll go, well, you're the doctor, you tell me, but you can talk to them in a way that, it's really important that I understand what you think is causing your pain. Because if they think they've got cancer, for example, that's going to increase their anxiety, that's going to increase their pain, and they're not going to engage in self-pain management if they think they've got cancer. We also need to find out what they believe about their symptoms. So when their pain increases, a lot of people obviously think that means their pain's getting worse or their condition's getting worse. It's not necessarily the case. I've learned over the years also to find out people's anatomical beliefs, and I don't mean I expect them to have a degree in biology, but I worked with one person who she thought her skull was balanced on her spine after surgery, and she really thought that any sudden movements, her head would fall off. Now, until I've helped her or someone's helped her to understand that that's not the case, she's not going to start moving. I also asked people what they think about investigations they've had and the effect that they've had, or the effects that the treatments have, because patients will often have an investigation, it's come back as normal, and they'll blame the medic or the dentist or the doctor for not doing something properly, not looking at the right place. So again, I need to know that. And of course, it's really important. A lot of people can't really verbalize their thoughts, but they can describe images, and especially with TN, people describe it as something sort of lurking behind them, waiting to jump out at them. So just learning and understanding about all those things about your patient is going to be really useful to reassure them. I'll explain why I'm using the avoid little captions in the bottom. There's this thing called catastrophizing, which it's been around in the pain literature for quite a long time. And we know, I won't go into detail about this slide, but we know that when people think about the worst possible outcome when they have pain, they tend to catastrophize. They then become fearful of movement and injury and more pain. And so they end up avoiding lots of things. And they end up in that whole cycle that I described earlier on that messy slide. There's been some work out recently, thank you, Joanna, for sending me that paper, to suggest that try not to use the word catastrophizing with patients, because patients tend to think that they think you're saying you're being a bit dramatic. Actually, catastrophizing in a psychological term just means thinking about the worst possible outcome. They're not being dramatic, they're thinking in a negative way, which is understandable. So don't use the word catastrophizing, but look out for it when you're talking to patients. Sorry, my animation's gone wrong there. Cognitive processing, mood will affect how your patients think about things, look at things, listen to you, hear what you're saying. So cognitive processing mood will cause biases in processing. Sorry, I didn't say that very well. Mood will cause biases in processing. It will distort what the patient pays attention to and hears what you're saying or what they see. If they're depressed, they will focus on the negative. So they might have loads of different things around them, some of them happy, some of them positive, but if they're feeling depressed, they'll just focus on the negative and just remember the negative. A silly example is if someone said to me, Claire, I like your shoes, but I hate your trousers. If I was depressed, I'd forget the like your shoes comment. I just focus on the hate your trousers. So when you're giving patients news or information, and some of it's negative, some of it's okay, make sure you know that they've understood the both sides of things. And anxiety is a similar thing, but it focuses on threat. So if somebody, for example, thinks their pain is caused by cancer, they'll be looking out for your word, and they'll be thinking about cancer. So if you say it's not cancer, that person may well hear it is cancer, because they're just focusing on that word. So again, you need to be checking what they're hearing, what they're going away with when they've when they've seen you. And in terms of the behaviours, so we do all this in the pain management programme, but I'm just laying on the fact that you can actually do this a little bit as well. In terms of the behaviours, there's a lot of avoidance around with pain, and of course that's absolutely understandable. We're all taught from when we were little that if you have pain, rest, don't make it worse, look after yourselves. And unfortunately that keeps going when people have persistent pain and things like TN. So people will avoid a lot of stuff, and their avoidance will get worse. Our role is to help them to reduce that avoidance, helping them to understand pain, but also the disadvantages of avoiding things. Because these people do not want to go and do things that they think will cause pain. So of course they avoid it. Makes sense. So we actually help them to start engaging in behaviours that they're actually frightened of. I remember working with one man in the programme I'm going to talk to you about in a minute, and he was a lovely guy. He came in very dishevelled and wasn't shaving, and he gradually got himself to be shaving over the time, and he came in the last time with a beautifully shaved face, looking really well and really happy, but he was terrified to start with. So we would ask them what they want to start doing and help them to do it. And we'd also ask them we'd teach them how to challenge unhelpful beliefs, such as, what if I go out and have an attack? And we help them to challenge that with getting them to do these incongruent behaviours, so that they go and test out these beliefs, because they might not be right. They might be, but they might not be right. And if they are right that they have an attack, then we help them to manage how they learn to deal with that when they're out. So that's the behavioural side of things. We did. I've done a CBT pain management program for TN when I was at the Eastman Dental Hospital with Joanna. And we've followed patients up at 1 and 9 months. There was a 100% retention rate, and that's actually quite unusual for a pain management program. So that's great in itself. People benefit often with pain, including TN, from a group format because they don't feel so isolated. They can share experiences. People will increase their confidence to manage everyday tasks. They reduce their negative beliefs about pain, which is really important, and increase their engagement in meaningful activity. So this is about improving quality of life. They probably would have said they had the same amount of pain. If they said my pain has reduced, it may well be that they're not focusing on their pain as much. If we could measure pain, which we can't, it might be that their pain hasn't reduced. It's just their way of thinking about it has changed in a more helpful way. So how can you help? Whenever I do talks to non-psychologists and I go on about words, and it's the words you use and how you talk to patients, I often hear, I haven't got more time to spend with patients talking. This isn't about spending more time. It's about you and your words that you use, and also your beliefs. I've put the little CBT model up there because it's also about thinking about what you believe about these patients. It's not about more time. It's about your understanding about and beliefs about pain and psychology and the patient. I've worked with people in the past, not loads, but people who think that psychology is for people who are a bit mad, and if the patient cries and is really panicky, then they're exaggerating or malingering or whatever. That's not the case at all, and we need to shift our beliefs if we think that, to be more understanding and empathic. And it's about the words you use. Our words can be really, really harmful. This is a phrase that I picked up from a paper. We are powerful co-creators of beliefs about pain, and these beliefs endure over years, and they drive distress and disability behavior. I've worked with people in the past who've said that a doctor, I don't know, maybe 20 years ago said, don't do X because Y might happen, and they just haven't done X. And it's really difficult to shift that belief. So we can reinforce, unless we're careful, we can reinforce avoidance, increase fear, depression, and worry, and we can reinforce incorrect beliefs about pain. Just a little tip: avoid the word catastrophizing, avoid the phrase "you need to learn to accept your pain." These are all right, but patients do not accept these phrases. It's not about accepting your pain. It's learning to manage your pain, live alongside your pain. Avoid the idea of talking to patients that anything psychological can increase or cause their pain. Stress doesn't cause pain. It can increase pain, but patients don't like it when you say stress leads to pain. They get the pain leads to stress, but not the other way around, a lot of them. Oops, sorry, don't suggest that they're avoiding things. They don't like the word avoiding because they feel criticized. And although in the literature you will see that TN is known as the suicide condition or suicide pain, I would say try and avoid saying that to patients, because you're telling them in a way, or to some patients, that this is so bad that some people end up killing themselves. And that in itself is quite an unhelpful message. So this is an example. I worked with a patient. A dentist said, it was not a TN patient, but it's a good example of a very well-meaning dentist that just said, oh, your jaw's a bit loose. This patient was really anxious. And of course, if you're anxious, you extrapolate about what might happen. So my jaw's loose, you extrapolate into the future. She began to think her jaw would fall off. Now, you automatically do something to cope with this. You can't go around holding your jaw because you can't live your life like that. What this lady did was tie some tights around her head. Very sensible if you think about it, but it looked a bit crazy. And this woman, of course, would walk down the streets with a pair of tights over her head, and she got labelled in an unhelpful way. But if you understand what she's believing, and this is what I was talking about her interpretation, if you understand what she's believing, what might seem odd behaviour makes absolute sense. And then you can help her change her cognitions, and then the behaviour might change. So I've said that really. We need to really avoid labelling people with TN and their behaviour as odd. I've already put that on the other slide, sorry. And we need to understand that their psychological reactions, but also the behavioural reactions, can be understood in terms of normal psychological processes, not psychiatric processes, normal psychological processes. It's fear and it's anxiety. And unusual behaviours will make sense when you know about what's behind the thought. Sorry, what thought's behind the behaviour. And we don't have to lay a pathological psychiatric explanation on these patients. So I would say that when you're with patients, there's an absolute opportunity to help correct any unhelpful, disabling beliefs about the cause, meaning, and consequences of their pain. You can help this. And patients can really feel heard and listened to if you just give them a chance to talk about their pain and about what's causing their distress. And also, you can help, not necessarily totally halt or totally help them to manage their pain, but you can certainly help them to some extent to understand their pain. So it's all about, I think, don't assume and talk at the patient, you know, you've got TN, this is what it is, blah, blah, blah. It's about being curious. And as I said, what do you think is causing your pain? What do you think is happening in your face to be causing your symptoms? This might sound like an odd question, but what's the worst thing for you for having about this condition? That could be, I might die, or I've seen one of my friends who's lost their job and their mortgage and their house went. There could be so many answers to that. And I guess that this next question is a similar one. Many people have concerns or worries when they have this condition. What are yours? That normalizes it. I often use that quite a lot. A lot of people think like this when they have your condition, because people can feel a bit mad when they're talking about how they feel. What do you think is happening when your pain increases? The answer to that might be an unhelpful, well, I've got a tumor that's full of cancer and the cancer's getting bigger. You want to know that if you're going to work with this patient. So in psychological terms, it's actually sort of a way of being. It's about way of being with the patient. I watched a video, it was a really good video, Joanna, today, of you saying, get rid of the computer, get rid of the notes in front of you, get rid of the sort of, I'm the expert, I'm knowledgeable, I'm powerful, I have all the answers. Instead, work alongside the patient. And yes, you are the expert in some respects, but then so is the patient in their experience. And you can learn from them about what they're experiencing, how they're feeling, and they can have the power too. And we can work together to hopefully find some of the answers. Now, I know on your own, as a single clinician, you're not going to give them all the answers. Of course you're not, but you can give them some answers. I've whizzed through that like lightning. There you go.
Okay, that was brilliant. Thank you very much, both of you, for excellent talks. That was a very good summary of trigeminal cranial neuralgias, and in particular trigeminal neuralgia. And we've just heard also about the different psychological aspects of facial pain and how we should be trying to manage our patients in that respect. What I'm going to do is I'm going to give people just a few moments to give me some questions to ask. There's a small box at the bottom of your screen which says Q&A. If you put some questions in there, I will scan through them. What I'm going to do is I'm just going to ask one or two questions myself first of all. So Joanna, first question to you. What proportion of patients do you think, or have you found in your experience, are completely refractory to every possible treatment for trigeminal neuralgia? So you know, what proportion of patients are real heart sink patients where everything you do just doesn't work?
Well, I think that is very much what Claire was talking about. I would say, yes, there are some that are medically refractory or even surgically refractory. But I think that if we can offer them the full package, I think we can do very well with them. And touch wood, I haven't had a suicide among my patients over the 30-odd years. So I think it's very much about teaching them how to manage and live with the pain. And I think that's the mistake we make, that we get labeled as refractory when actually we haven't fully looked at the drugs they've used, evaluated the drugs carefully, and given them that package together. The last thing I find very annoying is when we get referred patients and they say, well, we've done all this and this huge list. Now you do the psychology. We do it at the same time. So the moment we have our patients for the first visit, we'll already be assessing them. Do they need some psychological support? Are they catastrophizing, which is a term we're not supposed to use. We're supposed to use concern about pain. So if we find these concerns, it is about managing it this way. So I don't fully believe in a refractory patient.
Okay, that's very useful to know. I mean, one of the problems that many people who are logged in to listen to you speak today will find is, and I'm certainly one of these people, is that clinical psychologists are a very rare breed, and up and down the land there are lots of big neuroscience centres which just don't have access to clinical psychologists, and so sometimes we have to try and manage this on our own, which again can be very challenging. A very different condition, functional neurological disorder. What we tend to do as neurologists is we tend to, if we don't have access to the right people, we tend to direct them towards a website, which you're probably familiar with, called Neurosymptoms. Are there any websites or patient self-help sites that we can direct people towards to think about the psychological aspects of this, you know, so they can help themselves rather than being referred to one of these mysterious clinical psychologists that we can't ever find? Have you got any recommendations there?
Joanna, I'm going to ask you a question here. The TN Association website, is there any psychology on there?
Not much, I'm afraid, at the moment. It has changed considerably. But I think one of my roles as sort of having set up my Trigeminal Neuralgia Institute is to improve that approach and to provide evidence of the need of this. And that's why looking at our CPRD records at the moment and the patient journeys is going to give us some ammunition, I hope, to prove that we need more psychology support in our clinics. I think you deal with so many different problems. I mean, the migraine patients, the tax, there are so many headache pains that we need psychological support. But I think as clinicians, medical clinicians, we need to appreciate the need to have that extra support. I used to have to do it on my own when I worked at the Royal London. I had to learn it myself, so it was a great favour to suddenly find I had a team. And I think that's what we've got to be working towards. We've got to show that it's also economically viable to have a multidisciplinary team. And I can't stress that enough. We need an MDT team.
So as far as I know, if the TN Association doesn't have anything, I suspect there isn't much at all out there, which the things I want to do before I die, I'll write a book about it. But I would say, in the absence of that, and I wouldn't say this to all patients by any means, there are some good chronic pain, cognitive behavioural pain management resources out there. The problem is a lot of them are focusing on back pain or MSK pain. Now, from a psychology perspective, I would use a similar model, similar words, not all the same, of course, and I'd adapt it to the patient. Some of your patients might accept that. They may be all right looking at those websites or resources, but a lot, I would imagine, aren't, because they just go, it doesn't relate to me, I'm different. So I would really, and it's very difficult to judge who will accept that. So, I mean, bottom line is I'm saying no, aren't I? There isn't much out there. This is why I'm really, really keen for the more medical professions to use the language themselves, get used to what they can say and do to help patients just reduce their fear. I think if you can help them to understand TN, no, it's not going to kill them. Yes, it's difficult, but they can learn to manage it. This is what it is. It's a step that you can absolutely help them with.
Great, that's
very much the focus of the International Word Congress that I've just come back from. Very big focus on patient involvement, and there was a whole workshop on the linguistics and the words we use, just as Claire's been talking about, words we avoid and how much damage we cause by the words we use. And therefore, I think a good thing is, I find when I have my trainees sitting in, is that I look at the words they use, their non-verbal behaviour, and feedback to them. And perhaps we need to do a little bit more of that. Have somebody else sitting in your clinic, say if you've got your trainees, get them to look at the way you conduct the interview, not just the diagnostics and the management plan. Is what words are you using? How are you using them? How is the patient responding? Are they listening? Have you got their attention? Are you giving them time to talk?
So I've got one or two questions that have come up now. There's an interesting one actually about hallucinogenics. I mean, I have had patients over the years that have had used magic mushrooms to treat their cluster headache, and I think there is some evidence that psilocybin, which you can't obviously get hold of, can help in some types of pain disorder. Is there anything at all in the trigeminal neuralgia world on these drugs?
No, not as far as I know, and I don't know enough about the other tax, that is cluster headache. I don't really deal with those, so I'd say no.
Right, okay. I have another question here. Does idiopathic facial pain exist, or is it another condition that's just been diagnosed?
No, it is, and there are patients in whom no neurovascular compression is found. What the neurosurgeons are now doing is what they call internal neurolysis, because there's a concept that perhaps what's happening is it's the arachnoid is causing some of this compression. So what they do is literally comb the nerve. But as a result of doing that, you have a bigger chance of causing sensory change, because obviously you are now interfering with that nerve. But there are patients who do well with this combing of the nerves, but you need to warn them about sensory change.
Right, okay. And in the future, do you think we'll ever have any form of electrical stimulation to treat patients with trigeminal neuralgia in the same way that we have supraorbital nerve stimulators and we have occipital nerve stimulators?
Yes, I think there might be. Neuromodulation is something out there, and one of our neurosurgeons is looking at the use of metacortex stimulators and things. So there may be some value in it. The big problem is we still haven't got an animal model of trigeminal neuralgia in order to look at this, because it remains an episodic pain, and that's the difficulty. Just tying the infraorbital nerve of animals isn't working. Although I do know that horses suffer from trigeminal neuralgia. But that's the only animal I've heard of who actually has trigeminal neuralgia, can have trigeminal neuralgia. So that's our problem.
Right. Well, that was very useful. So as a final plug, because I found out that I didn't actually put it in the chat, if people do want to, and I'm sure everyone listening wants to join BASH if they haven't already joined, but they need to go to the website BASH, that's bash.org.uk, and there is a tab where people can click to become members. So for those of you that aren't members, if you go and do that now, that'd be great. I'm going to close this webinar this evening. I'd like to thank both of our guest speakers, Clare Daniel and Joanna Zakrzewska. The talks this evening have been fascinating, and for those of you that joined late, I will be slightly editing this webinar, and we'll then put it on YouTube, and it'll also be available on the web BASH site. Thank you very much and good evening.
Thank you.